Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. Today, in continuity with the previous series, we are starting with another interesting part in CNS examination, that is localization of lesion. Once you understand how you examine the CNS and how you interpret those CNS findings, you should be also aware of how you localize them, how you put them, and you will be able to find out where is the lesion, why is the lesion, and what is the etiology. So you will have to find out where the damage is, what type of damage, and what is the cause of damage. And that will be possible if you understand how you localize. So today in localization of lesion, we'll be dealing with what we call as localization of neurological lesion, but syndrome wise localization. So first you should understand that, and then we'll be going to localization of stroke, localization in hemiplegia, sensory localization, brainstem localization, peripheral nerve, muscle, spinal cord localization, etc. So for that localization, we should be aware of all the different physiology of CNS, like descending tracts, ascending tracts, etc. So this is pyramidal system, this is extrapyramidal system, and this is ascending system. So that is extrapyramidal, this is sensory, this is pyramidal system. We have to be aware of these three common tracks: descending tracks, ascending tracks. Pyramidal tracks and extrapyramidal tracks are descending tracks, while ascending tracks are all sensory tracks. For localization, history is absolutely necessary, followed by examination. And once you finish history and good CNS examination, we should be able to say where is the lesion, that is anatomical localization, what part of CNS is being involved, that is physiological localization, whether it is sensory, whether it is motor, whether it is autonomic, whether it is extrapyramidal, etc. And then why is the lesion, that is etiological localization. When we put all this together, we call functional diagnosis. So we'll be going through that. First, we have to answer a question: is there a lesion in CNS? If answer is yes, we go to the second question: where is the lesion? That is site, or we call anatomical localization. And then we try to identify what is the lesion, that is physiological localization, whether it is pyramidal system, extrapyramidal system, whether it is autonomic nervous system, whether it is muscle, whether it is peripheral nerves, etc. That is we call physiological localization. And why is the lesion? That is we call etiology, whether it is infective, whether it is traumatic, whether it is vascular, whether it is demyelinating. So after putting all those together, final diagnosis will be, we call as a functional diagnosis, which includes anatomical, physiological, and etiological. So that we call as final diagnosis. So this particular you can do even without CT, MRI, or CSF examination. And that is what is being needed by any particular person. There was one person who has described Occam razor, that is, after doing all this, he is mentioning KISS principle. K is for keep, I for it, S for simple, and not stupid. So if you go properly, you take a good history, do a good examination, try to locate where is the site, what is the physiological damage, what is the etiology, probable etiology. You will be able to come to the nearmost diagnosis, we call it a final diagnosis. And then for confirmation, we might require investigation like CT, MRI, or CSF examination, EEG, etc. So neurological examination always says you can see a lot just by observing, and you can see only what you know. So your knowledge regarding localization should be good, and CNS examination. So localization of CNS examination without CT or MRI is absolutely necessary. So what makes that? Practice, practice and practice makes man perfect. So a good CNS examination makes you perfect. So good history followed by a good CNS examination is a best way of doing localization without CT or MRI. And for that, we have to be aware of what is central nervous system, what is peripheral nervous system, what is somatic nervous system, what is autonomic nervous system, etc. Then we'll be able to localize where, what and why is the lesion. So a good history from the patient regarding symptoms and signs, origin, duration and progress, family history, past history, personal history and history of taking drugs, vital data examination followed by general examination followed by CNS examination and then systemic examination like CVS, RS, elementary, etc. And then for final confirmation, investigations. If person is having altered level of consciousness or person is unconscious, he is having psychiatric disorder, children or newborn, if person is having aphasia or aphonia, dysarthria, or he is deaf and dumb, or he is having dementia, or he is a mentally retarded, we need to take a good history from relatives, friends, or the person who is along with that particular patient, or from the nurse or from the doctor who has treated him in the past, etc. So a good careful history and good examination gives you lot of answer. And in CNS examination, we know higher function examination, cranial nerve followed by motor system, which will include reflexes, posture, gait, equilibrium, sensory system examination, look for involuntary movement, coordination in cerebellar examination, sphincter, and if person is unconscious, the examination will change. Autonomic nervous system may be required in some of the person. It should also include CNS examination, that is examination of spine, examination of skull, meningeal signs, and we call as a brainstem signs. So these are what we call as a meningeal signs, Brudzinski signs, Kernig signs, neck rigidity. Then what is the type of a posture in an unconscious person, whether it is flex, whether it is extension, or whether it is flaccid. You can go for a brainstem signs like Dolce movement, caloric test, etc. So for confirmation of the CNS lesion and localization, we require whether there is a CNS lesion, answer yes or no, then you can proceed with history, examination of CNS, and then we try to locate whether it is central nervous system, peripheral nervous system, autonomic nervous system, whether it is upper motor neuron, lower motor neuron, whether it is intracranial, extracranial, etc. from good history and examination. Then we want to find out why there is a damage. So we want a etiology. For that, we have to go for good history and examination followed by investigations. And after making a proper diagnosis, we can decide regarding a treatment, regarding a prognosis, regarding what person will develop morbidity or mortality. Among the common etiology in neurology is infection, trauma, vascular tumor, degenerative, congenital, immune mediated, nutritional disorders, toxic, chemicals and drugs, iatrogenic, and it can be also idiopathic. Now, normally when you approach to examination, after doing a higher function speech, cranial nerves, motor system, reflexes, sensory system, involuntary movement, cerebellar examination, posture, balance, gait, meningeal signs, spine, skull, etc. We should be able to put them into any one of these 9 syndrome patterns we call. So either you go from, is it cortical, it is subcortical, it is brainstem lesion, or cerebellum, or spinal cord, or nerve roots, or peripheral nervous system, myoneural junction, or muscle. These are the 9 patterns which you can identify very easily after doing a good history, good CNS examination. We should be able to pinpoint, and then putting them into any one of these syndrome groups, we should be able to also pinpoint close to the etiology side. And that is what we call as localization of lesion. So we are starting with first, that is muscle. Whenever a person has got a pure muscle involvement, without involvement of other parts, that is cortex, subcortical region, spinal cord, cranial nerves, peripheral nerves, motor roads, etc., or even myoneural junction. What we have to find out whether it is proximal, symmetrical or not. Usually, good number of time, pure muscle involvement is usually symmetrical and without sensory loss. So whenever a person comes with a muscle involvement and there is no sensory loss, we try to find out what type of muscle involvement it is. It is symmetrical or asymmetrical. And in that also, proximal or distal. Person who finds difficulty in getting up from sitting posture or getting up from squatting posture, it will be proximal muscle involvement. And if a person is finding difficulty in lifting bags or small children's, that means proximal muscle weakness in upper extremities. And there will be absolutely normal sensory findings. There will be no involvement of sensory system. And person might have a symptoms related to muscle like myalgia, cramps, etc. This will be peculiar, which will be pinpointing to muscle involvement. And whenever there is a proximal muscle and symmetrical weakness without sensory loss, and muscle are normal in size, there is no atrophy, no fasciculation, tone and dip tendon reflexes are normal or slightly diminished, you must suspect this to be a disorder related to muscle we call as a myopathy. So proximal muscle weakness, very peculiar. You can easily identify person will find difficulty from getting up from sitting posture or lifting up objects. Second big groups, neuromuscular junction disorders, which is identical like a neuromuscular junction disorders, is almost like what we call as myopathy groups, where person is having proximal muscle weakness, but here the person will have proximal and variable weakness, and there will be no sensory involvement. The muscle will have waxing and waning, and person will get involvement of the muscle in the form of fatigue. Classical example of that is myasthenia gravis. So person will get fatigue with prolonged activity, and particularly the muscle which are constantly in action, like extraocular muscle, eyelid muscle. So person will develop bilateral ptosis, and movement of the eyeball will be affected. And as soon as the person takes rest for some time, the muscle function will improve. This is very peculiar in myasthenia gravis. While if a person strength improves with activity, it is in one group of symptoms like myasthenia syndrome. So it resembles identical like myopathy. So fatigue muscle, fatigability of proximal muscle without sensory loss, loss of strength after exercise, particularly ptosis, and also extraocular muscles are being involved. Muscle will be of normal size, no atrophy, no fasciculation. There will be normal tone, and dip tendon reflexes will be also normal. we should put first possibility of myasthenia gravis. Very peculiar. After rest or even after ice application, the ptosis will improve. And that is also one of the things which will tell you that this is more in favor of myoneural junction, that is myasthenia gravis. The third group we call peripheral nerve. By and large, in a peripheral nerve, it will be always distal muscle being more involved. So, person will have like foot drops in upper limb, wrist drops. So, person will have dragging of the feet, wears out toes of the shoes. There is a trips in upper extremity. The person will drop the objects. There will be problem with gripping, that is like writing, holding the objects, etc. Invariably, there will be asymmetrical weakness depending upon the nerve which is being involved. And one of the most common cause of nerve involvement is compression syndrome like carpal tunnel syndrome, sciatica, Bell's palsy, etc. In some of the condition which involves the peripheral nerve, you can have a symmetrical weakness, and this is very common with metabolic disorders like diabetes. And as there is an involvement of the peripheral nerve, you will have motor plus sensory. So good number of time along with motor involvement, there is a sensory involvement also. And in peripheral nerve, there are a lot of different types of presentation like pure motor, pure sensory, mixed variety. Good number of time it is a mixed variety, so you got a motor weakness with sensory symptoms and signs. And it is damage to the peripheral nerve, so it will produce lower motor neuron type of a damage, which will produce muscular atrophy, twitching, and fasciculation. And as far as the sensory changes is concerned, right from positive symptoms to a negative symptoms, positive symptoms like paresthesia, hyperalgesia, neuralgia, etc. And in a negative symptoms, anesthesia may be partial, may be dissociative anesthesia to the total anesthesia. And you will have two groups of symptoms and signs like upper motor neuron defects and lower motor neuron defects. In lower motor neuron defects, flaccid weakness, atrophy, fasciculation, hyporeflexia, and Babinski will not be demonstrable because there is no upper motor neuron damage. And if there is a damage at the level of alpha S1, the plantar reflex will be absent. And if it is the upper motor neuron type of a damage, but this is more common if there is a damage close to the spinal cord. So if there is a damage close to the spinal cord and in the spinal cord, then only we will come across upper motor neuron type of variety of damage. In that case, we will have a spastic weakness, no muscular atrophy, no fasciculation, hyperreflexia, and plantar will be extensor, or we call Babinski, will be present. So, in examination of peripheral nervous system, by and large it is asymmetrical weakness, atrophy is very common, fasciculation is very common, sensory finding is common, and as far as the muscle tone is concerned, we might have hypotonia because it is a lower motor neuron type of a damage. Deep tendon reflexes are diminished or may be absent, and we may have also autonomic changes like trophic changes, vasomotor changes, etc. So those findings will be very, very common in a mixed variety of a damage. But we can have pure sensory, pure motor also. We'll be dealing separately when we do approach to peripheral nervous system or approach to sensory. So this will be the type of, and it will be sensory loss will be in the distribution of a nerve supply. So it will be distribution of peculiar nerve supply distribution. So that will be very typical. So we should be aware of which reflexes are involved with what particular root value. Say plantar reflex alpha S1, knee jerk L3, L4, ankle S1, S2. If we take bicep, it will be C5, tricep will be C7, brachioradialis will be C6, and if we go to what we call as Hoffman's sign of finger flexion, C8, and because of now atrophy, you will start getting wasting and fasciculation. You will have a sensory disturbances. Now, if we come to the root, root means close to the spinal cord. Whenever root is involved, if anterior root is involved, it will be motor. If posterior nerve root is involved, person will have a sharp stabbing pain, which is electric shock like pain, shooting pain, radiating pain. This we usually label as neuralgia. And person will have resembles like peripheral nerve, but weakness may be proximal or distal depending upon the nerve root involved. So if the common spinal nerve is being involved, which is containing two fibers, posterior nerve root fiber and anterior nerve root fiber. So if anterior nerve root is being involved, we'll have motor involvement. If posterior nerve root is involved, we'll have a sensory symptoms like neuralgia. And if a spinal root is involved, we'll have both symptoms, sensory as well as motor. In case of upper extremities, more commonly we have got a proximal muscle involvement, while in a lower extremity it is more of a distal muscle involvement like alpha S1, while in a upper extremity C5, C6 is the most commonly being involved, which will produce involvement of deltoid, etc. So that is the pattern of involvement. So in that particular we will have a motor signs as well as a sensory signs. So in upper extremity we might have involvement of a bicep, tricep or supinator, while in lower extremity we will have involvement of the ankle jerk, knee jerk or plantar reflex may be affected. So in a nerve root involvement, distal is often asymmetrical, and because of motor involvement, atrophy and fasciculations are very common. Tone invariably is decreased. We get hypotonia because it is a lower motor neuron type of a damage. Deep tendon reflex will be reduced or may be absent with the involvement of the nerve. Sensory loss will be depending upon the dermatomes which are being innervated, and maneuver that stretches the nerve will produce pain, and that is SLR or Valsalva maneuver. This will be a peculiar finding in a nerve root damage. So nerve root damage and peripheral nerve will be very easily differentiated. If you get peripheral nerve signs with neuralgia, do suspect nerve root damage. As we come to spinal cord involvement, spinal cord will be containing ascending tracts, descending tracts. So there will be sensory level, very clear cut, and which is the diagnostic part of as far as the spinal cord involvement is concerned. And below the level of damage, we'll always have a upper motor neuron type of a damage, like spastic weakness, increased tone, reflexes will be brisk, and plantar will be extensive. That will be very peculiar. And at the level of damage, it will be lower motor neuron type of a damage. And above the level of damage, no involvement of motor system. This is characteristic of spinal cord damage. And because the bladder and bowel centers are present in S2, S3, S4, so any damage above the S2, S3, S4, you will have a bladder involvement, which will be of upper motor neuron variety. And if we get the damage at the level of S2, S3, it will be lower motor neuron variety. And if there is a damage below this, the bladder and bowel will be spared. This is a peculiar, this we call as a triad of symptoms, sensory, motor and bladder and bowel function involvement will be characteristic of spinal cord involvement. So maybe depending upon where is the damage, you will have involvement. So motor involvement, sensory involvement and bladder and bowel involvement. So at the level, lower motor neuron, above the level, upper motor neuron, sorry, below the level, lower motor array, at the level, lower motor neuron, below the level, upper motor neuron damage, and along with sphincter dysfunction, particularly bladder and bowel. While sensory, below the level, if there is a complete transection, all sensation are affected. And depending upon the amount of damage, you can have sparing effects, etc. At the level of damage, you can have hyperesthesia, 1 or 2 segment above. And above that, sensory system, motor system, reflexes, everything will be normal. This is a characteristic of a spinal cord damage. So in a spinal cord damage, you will have a pyramidal tract gone, spinothalamic tract gone, dorsal column gone, etc. are involved, as well as the sympathetic system, parasympathetic system will be also involved. So these are all the different presentation. This is commissure damage. This is sensory loss with sacral sparing, that is intramedullary lesions. This is Brown-Séquard syndrome. We'll be dealing separately all those things. Now in a brainstem damage, it is very peculiar that because if there is a damage in the brainstem, on the side of the damage we get a lower motor neuron type of a cranial nerve palsy, and we get involvement of the corticospinal tract which crosses to the opposite side in the lower part of medulla. Hence we get opposite side corticospinal findings in the form of hemiplegia. And on the side of the damage, we get a lower motor neuron type of a cranial nerve palsy, which can produce diplopia, dysarthria, dysphagia, dizziness, deafness, etc. This will depend upon which cranial nerve is being involved. So this is called cross hemiplegia or contralateral hemiplegia. Hence, this is a characteristic finding in a brainstem damage. We are not dealing in detail at present. We'll be doing separately in one approach to brainstem localization. So very characteristic, and in a brainstem localization also we can get involvement of cerebellum also. So that is a part of brainstem localization. So we'll always have what we call as a crossed hemiplegia or contralateral hemiplegia. So very peculiar ipsilateral cranial nerve palsy and contralateral upper motor neuron variety of hemiparesis or hemiplegia. So you get involvement of pyramidal tract, spinothalamic tract, medial lemniscus, spinotrigeminal tract, cerebellar, peduncle, etc. So you can have even cerebellar signs. Depending upon the level, I am not going at present. So depending upon which level you get involvement of sensory pathway, you get involvement of cerebellum. So when we get a pure cerebellar damage, you can have a pure cerebellar findings in the form of incoordination and intentional tremors. So person will have incoordination, imbalance and involuntary movement in the form of a tremors. This is a very characteristic of a cerebellum. If you get a hemispheric lesion, means you get only one side cerebellar hemisphere damage, you will have a finding on the same side of the body. So if there is a right side cerebellar damage, you will have a right upper limb and lower limb showing you incoordination and involuntary movement. If you get a vermis lesion or a bilateral cerebellar hemisphere lesion, you will have a bilateral findings. So that is the characteristics. So in a cerebellum, we get incoordination, imbalance, and we'll have difficulty in maintaining posture and equilibrium. So that is very characteristic of cerebellum. So In those, lot of science again will be dealing in detail in cerebellum. Now there are two things. We'll be dealing with subcortical lesion and cortical lesion. Now, very simplified form, in a cortical lesions, we'll have altered level of consciousness if there is an extensive damage and bilateral damage. But if it is a unilateral damage, person will be usually conscious. And in a case of a unilateral damage, depending upon the area which is being involved, say if it is a dominant hemisphere, person can have frontal lobe involvement, or we call as a aphasia will be very common, and it will be a Broca's aphasia. If parietal lobe is involved, person will have a Wernicke's aphasia with sensory findings. In a frontal lobe damage, you will have a motor finding, but there will be sparing effects. If there is an occipital lobe involvement, person will have a homonymous hemianopia with macular sparing. If there is a temporal lobe involvement, you will have auditory findings, you will have olfactory findings, etc. So depending upon which portion of the cortex is being involved, you will have findings. If you have got a Wernicke's area and associated area involvement, you will have agnosia, apraxia, alexia, etc. So this is what will be in a cortical involvement. You will have also higher sensory function involvement like localization, discrimination, 2-point discrimination, stereognosis. All those will be a common finding in cortical damage. While in a case of a subcortical damage, usually person will not have aphasia, agraphia, alexia, apraxia, etc. will not be there. This will be a very simple way to differentiate. In a case of a brainstem damage, and particularly pontine and medullary damage, person will have an altered level of consciousness, which in a case of a cortical damage, you will be able to see those particular findings only if there is a bilateral cortical damage. In a unilateral cortical damage, usually person will not be unconscious unless he has got associated brainstem damage. So if there is a dominant cortical hemisphere damage, person will have aphasia, agraphia, alexia, apraxia, etc. And if it is a non-dominant hemisphere, person will have classical what we call as adjustment syndrome, where we call hemi-neglect. Also there will be agnosia. So, and depending upon the damage, inner cortex will always have a sparing effect. Upper limb may be more involved as compared to lower limb, or lower limb may be more involved as compared to upper limb. So if there is a MCA territory, upper limb and face will be more involved as compared to lower limb. And in a ACA territory, the lower limb will be more involved as compared to the upper limb and face. So there is always a sparing effect. And also there is a sparing effect as far as the sensory system is concerned. In a subcortical lesions, particularly if there is a damage in the internal capsule, it will be completely dense palsy involving upper limb as well as lower limb equally, and also may be associated with homonymous hemianopia and hemisensory loss on the same side of the hemiplegia. That will be very peculiar in case of an internal capsular damage, and very commonly it is because of the branches of middle cerebral artery. So that is very, very important. So cortical damage and subcortical damage, you should be able to differentiate very easily. Visual field loss in a cortical damage, usually unless we get the damage in occipital lobe, visual field is not affected. In a subcortical damage, visual field is quite commonly affected. Yes, there is one word in a case of a cortical blindness we call as a Anton syndrome, just out of way. But if we get a occipital lobe involvement, it is usually homonymous hemianopia with we call as macular sparing. We already mentioned that if it is a cortical damage, person will have aphasia and person can have even seizures. And as far as the motor finding is concerned, we have already mentioned that face and arm is more commonly involved as compared to lower limb. But if it is an anterior cerebral artery, lower limb will be more involved as compared to face and arm. While in case of a subcortical damage, it will be a dense hemiplegia, upper limb and lower limb will be equally involved. So we use the word dense hemiplegia. These are all the different types of syndromes, and we already mentioned in a cortical damage, we'll have a cortical sensory function being affected in the form of localization, discrimination, two-point discrimination, graphesthesia, stereognosis, etc. While in a subcortical damage, usually we will have complete loss of sensation. So primary modality will be lost. And we already mentioned in a visual field also, in a subcortical damage, we'll have a part of the visual field being affected. We call quadrantic homonymous hemianopia. While in case of a cortical damage, unless occipital lobe is involved, will not have any involvement of visual field. So I end my lecture here. So this will help you to localize whether it is cortex, whether it is subcortical, that is internal capsule, whether it is brainstem, whether it is spinal cord, whether it is nerve roots, whether it is peripheral nerve, myoneural junction or muscle. We divide into 9 patterns, and this will help you a lot in your everyday practice to identify where is the lesion. So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable. I appreciate that for spending some of the time with me. If you find this lecture is helpful to you, don't forget to press button like and subscribe, and you can share with your friends also. We'll be going to the next in localization of lesion regarding stroke, hemiplegia, etc.